Hello, my name is Carl. I am a pediatric emergency medicine doctor. Today, we are going to think about restraint and chemical sedation in the context of an agitated young person. How is it utilized? What is lawful? And is it safe? Everyone has the right to liberty and security of person. This is Article 5 of the Human Rights Act. It also says, no one shall be deprived of his or her liberty unless in accordance with a procedure prescribed in law. Before I continue, may I encourage you to join our community and the YouTube channel Small Kids, Big Emergencies with me, Dr. Carl. Today, the single most important takeaway message is that any form of restraint is always a last resort. There is almost always an alternative. Visit the Restraint Reduction Network to learn more. My second disclaimer is that this is an enormous topic. There is a wider literature. This talk does not replace your local policies or guidance. It is an attempt to summarize a few key principles on the topic. Okay, let's consider 3 scenarios to start things off. Ivan, he is 17 years old. He has learning difficulties and autism. He is nonverbal. He is partially sighted due to partial retinal detachment in his eyes from previous headbanging. He has been brought in by ambulance as he has been assaulting staff and has been distressed at his care home. On arrival, with 3 police officers, he is face down on a trolley with hands handcuffed behind his back. You are asked to give him an injection before he is uncuffed. What are you thinking? How do you feel about this situation? What is wrong about this situation? What do you do next? Now we have a different teenager, Adam, 17, brought into A&E by police due to suspected illegal drug use. He is currently posing an imminent risk of injury to himself and others. He is pacing, shouting and threatening staff. He appears incoherent, is unable to interact, is sweating and has dilated pupils. Does he need physical restraint? What about chemical restraint? What about his health needs? What about polypharmacy? Now we have Sonia. She is 15. She has a past history of post-traumatic stress disorder. Due to a breakdown in her social placement, she has come to hospital. She is demonstrating a persistent and very high level of agitation. She is kicking chairs and has broken a window, but is not directing her anger against any person. She appears frenzied and may be dissociated. What do we do? How do we proceed? These are all challenging scenarios. Think about what you would do. What factors matter in your decision making? What are your own cognitive biases? What safe options can you take that are both patient-centered and lawful? A helpful starting point is considering why the young person is agitated in the first place. Perhaps there is an unmet physical need or an untreated mental health problem. Perhaps there are drug and alcohol at play. Maybe the person is frustrated, has had past trauma, is overstimulated, is feeling a lack of control. Always consider, is there something wrong that can be acknowledged or apologized for? Think about how you can express genuine empathy, and always consider if there is anything reversible about the environment or about the patient or about the situation that might help. Other videos cover this in more detail. We are now going to look at the first important step, categorizing the person according to risk. Are they agitated but cooperative? Are they disruptive but not dangerous? Or are they delirious, not engageable, incoherent, and posing a danger to themselves or others? In addition, consideration of physical health risk and any underlying condition should occur in parallel. Let's first consider the low risk situation. Here, there is no need for physical or chemical restraint against the person's wishes. Consider if there is excess stimulation, reduce it, adjust the environment, the noise, the lights, the number of people. Consider unmet needs like hunger, tiredness, thirst, and potentially allow space and movement. Have they missed a medication? Are they in pain? They themselves may wish to take an oral medication voluntarily, as they know it helps their anxiety. Plan A is always verbal de-escalation and modification of the environment. Use a low sensory approach, avoid excessive stimulation, reorganize the environment, provide access to open space and fresh air within a framework of safety, and allocate trained or specialist staff whenever possible. Plan A is all about making reasonable adjustments, being professionally appropriate but flexible, involving others who may be helpful, and considering oral medication if other efforts are not succeeding. With respect to medication, in the setting of a lower risk scenario where the child is cooperative, it is typically appropriate to speak to your specialist or psychiatric team before progressing. That being said, the following are established and commonly used oral sedatives that may assist alongside verbal de-escalation. Lorazepam, first line, promethazine, second line, and olanzapine if they are not already on an antipsychotic. Again, the context for the use of oral medication is where the young person is cooperative and where other methods of de-escalation have only partially succeeded. It's important to know your drugs, know the onset, know the duration, and know the potential hazards. Benzodiazepines, for example, can cause respiratory depression, and lorazepam in particular, when taken by mouth, can take over 30 minutes for the effect to occur. Promethazine, whilst largely very safe, can have cardiovascular complications, so always consider if the person has a history of cardiac disease. Lastly, olanzapine. This could be considered if they are not already taking regular medication, but again, side effects should be considered and monitoring available. When choosing which medication to use, it's important to consider the child's background and the potential cause of the agitation. Developmental delay, autism, an existing psychiatric disorder, the presence of confusion or pain, the possibility of drug use, or indeed the situation where the cause is not known, all matter. The detail of this we're not going to get into. Instead, I'm going to talk about one example. The first question when thinking about using a drug for the purpose of reducing agitation in a young person is whether it has worked before successfully. Otherwise, when using a drug for the first time, the effects can be unpredictable and should be planned for. Benzodiazepines, on the whole, have a rapid onset and a very good safety profile. However, in the context of autism, they may have a paradoxical effect. There may be a heightened chance of increased agitation, increased aggression, increased impulsivity, and side effects such as respiratory depression are more common. On the other hand, benzodiazepines are an excellent choice in the setting of an unknown drug ingestion. Irrespective of what other drug has been taken, they are incredibly safe in this context. They act in all cases to reduce CNS excitation, making cardiac complications and CNS complications like seizures less likely. Essentially, they have a predictable safety profile in children when dosed appropriately, with rapid onset and titratability. Many guidelines and authorities endorse benzodiazepines in this setting. Of course, in the rare event of respiratory depression, airway support and the reversible agent naloxone should be used. Next time we will look at the scenario of a high-risk child, be them disruptive or dangerous. Take-home messages today: avoid restraint and sedation, think about reversible causes, categorize the scenario according to risk, always verbally de-escalate, and consider oral medication. Thanks for listening. Please consider liking and subscribing. See you next time.